Hello and welcome to the Spine Nerve Podcast. Thank you everybody for joining me once again. I am Brian Hoves and I have Dr. Jason Kung back. And Dr. Kung, thanks for joining me this morning and coming to talk about some fun new evidence that we have in the world of pain medicine.
New and ongoing. I think it's exciting to see more and more data come out, although as we were talking earlier, the data just seems to be coming out very frequently now and more frequently than we've seen in the past. So it's a lot to process, and if you sleep on it, you might miss something. So I think it was good to meet up again. I'm still here, folks. I haven't disappeared, just been doing other things.
Yeah, this whole, trying to take care of patients and all, it's sometimes gets in the way of us being able to podcast. But, as Dr. Kung was bringing up, one of the things that I think is really interesting about this modern world that we live in, medicine, though I think we like to stand on our ivory tower, kind of gets pulled into the headline chasing world that the rest of the world is. And so where if we go to years past, you didn't see studies published until there was, 12 and 24 and 36-month data to be able to assess at regular intervals. And the study that we're going to cover today, our main one, is looking at 3 and 6 month data, which obviously helpful, useful, adds to what we know, but at the same time is not exactly what we have historically been used to, because studies are just getting published a lot quicker because there is a lot of headline chasing and making sure people are constantly paying attention that's going on across the world, not just in our field. And so I think it's interesting that we get more data to look at, but at the same time, like Dr. Kung brought up, we always want to take everything with the right context. And so 3 and 6 month data, fantastic. Let's kind of keep tracking that longer term data, which will actually, a couple of the other studies that we'll bring up today start looking at some of that longer term data too. So Dr. Kung, you want to introduce the study that we're going to be mainly describing today?
Yeah, it's actually, it just came out actually in I think the November issue of ASRA. So it's actually 1 year data in addition to the 3 and 6 data that came out before. It's called the COMFORT study. I think most of us in the field know that this is this is for peripheral nerve stimulation, specifically of the implantable type, studying the Nalu system. They've been coming out with data 3 months, 6 months. They're actually planning for it to be about 5.5 years. So we'll see how long this goes for, but they just came out with the 1 year data. So what they're looking at is looking at PNS or peripheral nerve stimulation and just comparing that to conventional medical management. So they have a 2-arm setup with one using the nerve stimulation system and regular medical care to the control arm, which is just a conventional medical care. They allow the patients in the control arm to cross over after 3 months into the active arm. And the primary outcome is, most many other secondary outcomes, just looking at more than 50% pain relief, equal to or more than 50% pain relief. And so far, the 12-month data compared to the 3 and 6 is pretty solid and stable. Still seeing that there's about an 87% responder rate, being defined at more than 50% pain relief. The average that they actually found was 69% reduction in those responders. So still pretty robust and durable data from 12 months out. I think some of the key takeaways that I looked at this data is that if you look at the control arm, and maybe this can we can expand into this a little bit more. The conventional medical management we know is challenging when it comes to various types of peripheral nerve issues, neuropathy. So out of the 31 patients in that control arm, only one patient had relief with just regular medical management. I think, in my experience, that seems pretty standard. As far as looking at neuropathic agents or even nerve blocks that may just last temporarily. It's not really, we don't have a lot of good options, which is one of the reasons why we're talking today is use more advanced therapies to patients that really had not a lot of options in the past. What do you think?
Yeah, I mean, I think, when we're thinking about kind of peripheral nerve injuries and, so I think particularly even peripheral neuropathy, the data is pretty terrible as far as kind of conventional medical management, right? And so it is tough. There's the Cochrane review that's been published every 2 or 3 years for the past few decades, looking at all of the updates for medication management for treating these patients. And if you look at number needed to treat for most of those medications, it's somewhere between 5 and 9, which means 1 out of every 5 to 9 patients gets 50% relief of their pain with medications, right? And so, I think obviously we try them, we use them, but anybody can look at that and objectively say that's really not enough to be able to help our patients, right? 1 out of 5 to 9 is able to get 50% relief is not what we're looking for. And I think probably the reason why, generally speaking, people get very frustrated when thinking about these interventions that we have. When we're looking at the diagnoses treated, I think that's one of the, for me at least, going through the way that this study was kind of formulated. Obviously, people are going to respond to different things in different ways, right, for each different diagnosis. And so, this study in particular looked at low back, shoulder, knee, foot and ankle, so traumatic peripheral neuralgia. And they ended up updating it to include some post-surgical scar, nerve entrapment, mononeuropathies, and arthritis pain. But kind of specifically when their exclusion criteria was things like CRPS, peripheral neuralgia due to a metabolic origin or post-herpetic neuralgia. And so, when trying to kind of find the patient population that we're looking at, it still has a really, really varied patient population in this study. But it is nice to see that, in that pretty widely varied patient population, we are getting kind of consistent data across the board. And, this is where over time we'll have those kind of subgroup breakouts and be able to see specifically which diagnoses are the ones that are truly getting the most benefit from intervention like this.
Yeah, it's kind of a catch-all, not necessarily, but looking at a lot of different indications and seeing how this system works. And I really do appreciate that we have this data. When I explain this to patients, it's when people ask me for specific data on what's the success rate for this specific nerve issue that I have, oftentimes I just say I don't know, because we don't. Looking at what's out there, I feel as far as the safety profile compared to the success rate, I usually, at least for peripheral nerve stimulation, much more willing to try something for someone, knowing that it hasn't been robustly studied for that specific neuralgia. For a lot of patients that have some great success, and I'm sure you have success as well.
Yeah, no, I have definitely appreciated, over the past 5 or 6 years, being able to kind of utilize peripheral nerve stimulation a little bit more than I think historically was. I know it's been used for a long, long time, but now having devices specifically designed for peripheral nerve stimulation, where a decade or so ago, it was really utilizing spinal cord stimulation leads in that regard. And so they were, great technology, but at the same time, not things that were specifically designed to be placed into the periphery. And so having, updates and, Nalu obviously trying to create a micro IPG that's, kind of a different way of, a different level of amount of things that have to be implanted in a patient, right? I mean, that's the big hope and the goal, but I think, one of the things that I've tried to do when we're thinking about peripheral nerve stimulation is kind of trying to obviously erring on the most conservative side first. And so, one of the other things that, when we're thinking about the comfort study, we also start thinking about, okay, well, peripheral nerve stimulation, we have this temporary peripheral nerve stimulation in the SPRINT system that I think is really interesting to me because it's a 60-day placement, and then you remove the leads, and there's data that's been coming out that patients get some kind of more robust response to that, and that even continues on, right? And so, and that's where I think some of the data is becoming a little bit more specific. They're much like the comfort study. SPR initially had done a kind of a big study looking at just placement of the system, and then being able to kind of track overall are patients responding. And now specifically looking at some of the papers that have been coming out from ASRA, or the poster presentations from ASRA, which means that we'll probably be getting some actual papers written and published over the coming months and year. There's things that are much more looking at or diving deeper into very specific diagnoses. I think, we're looking at, they have the RESET clinical trial from Zach McCormick that got presented. So kind of randomized controlled study starting to look at specifically for low back pain. And so they're still early in releasing some of that data, but once again, that data looks very promising. And that study is actually comparing it to conventional interventional management. And so not just, kind of conventional medication management, but, say, okay, patients coming in with, chronic low back pain, we're actually comparing it to, what would be deemed appropriate if a patient seems like they follow into the medial branch RFA route or epidurals or things along those lines. And so, having a true comparison of what our other options are, and at least in their early data, I think they were at 3 months for that poster, showing a higher percent of patients achieving 50% pain relief. And so I think that's interesting, right? Now that's a little bit more kind of specific, and then there was the study that was published by Jonathan Gorey last year, looking at the SPRINT device for chronic knee pain after surgery, and so that was non-randomized controlled, that got published, that showed that patients were doing well with it. And so now we have a randomized control study, that's a double-blind study that's being started. And so being able to specifically look at the knee pain data, and for those patients that are coming out of or having chronic knee pain after total knee replacement. And so that's, I think, what, when we think about why the comfort study is so important, it starts the process, right, of being able to say, okay, we know that now this is a good tool. Let's really hone in and see where this is going to be the most beneficial for patients.
Yeah, full transparency. I have not done any Nalu cases, and it's not that I don't believe in their therapy, and it's just, it's a little more involved, right? It's more procedure for a patient. So anytime that I'm thinking about putting a device in somebody, timeline, I want to make sure that there's good evidence behind it. And as this data is coming out, because I'm going to have to get trained at some point, because it's really been good to see this data, and I feel like I have something a little comforting, no pun intended, but a little bit more to stand on to patients. And I've been more sprint forward. So many points that I just intentionally just said, but yeah, I've been more sprint favored, over the past few years, just because of minimally invasive. I've had patients that frankly, they just don't like having to care for the device because it's temporary. You have to have dressings on and changing it. And for some patients that really found that to be not something they want to do, we can remove it. Some of the responses I've seen have just been tremendous, especially with shoulder. I've just seen a lot of good. Maybe it's just bias and haven't done too many of them for shoulders, but some of the cases I've done have been really remarkable. Kind of leads me to this abstract that came out also at ASRA. It was a follow-up survey and just looking at patients with all sorts of different kinds of shoulder pain, whether it's post-surgical or more non-surgical osteoarthritis, and the responder rate was great. I think it was a study was published by Boggs, and it looked at the results was 71% of patients that were up to 12, 24, 36 months still had greater than 50% pain relief. 85% of those patients reported no additional interventions like stimulation, surgery. So it's I think the SPRINT data has really been able to do more specifically into these generators, and been able to give some clarity, talk to people.
Yeah. Yeah. And, you're talking about some of the longer term survey data. Also presented at ASRA, Chris Gilmore presented the 4-year follow-up for their first axial low back pain one. And so, now you have, 4-year follow-up that shows that there is a percentage of patients that is having sustained relief out to that point. I will say for low back pain, I have not seen patients out to 4 years in terms of their improvement. But I have, I have seen patients, for really strange pains that I don't know why they got better, honestly. Some of those kind of large thoracolumbar fusion cases where we don't really have a lot of interventional options, and you probably try an epidural or something like that and it doesn't help. I have a handful of those patients, that were now a couple of years down the road from trying a sprint on, and where they went from really severe, thoracic, low thoracic pain from in the area of prior fusion, and they're still doing phenomenal. And so I think that's it. Much like you, I think the idea that SPR or the sprint therapy is, a very non-invasive thing in my mind, to be able to help these patients. And there's a percentage of these patients that are going to, really get significant sustained relief, which is pretty amazing.
Yeah. On the flip side, when the patients get it, it's great. But when they can't get it for some reasons, like insurance issues, that's always it's always a challenge. And I think most docs, the frustrations day to day, just getting things for patients. And thankfully, for a lot of our older patients out there that are under Medicare or some sort of Medicare, for some of our local insurances here, they've been quite favorable. I think naturally there's definitely a struggle to get this therapy seen by insurance and favored by insurance to even get it. I know earlier this year there was I forget which insurance plan it was, but it was a Medicare Advantage plan through a national carrier, and they didn't cover it, and there was some backlash because they should be covering CMS covered procedures, and they eventually rescinded it. That just goes to show it's not just publishing the data and getting it out there; it's really presenting it to the right people and getting more coverage of it through national means. It's always a challenge, I guess.
Yeah. No, for sure. I mean, I think that is the big challenge, right? It's getting this approved. Dr. Kung and I were talking before we started. I haven't done a lot of knee cases because, for whatever reason, a lot of the patients that I see with, that have chronic knee pain after surgery, they tend to have some like PPO coverage, right? And so I know specifically at least, half dozen to a dozen patients that we tried to get this approved, whether it's, one of the Blues, United Healthcare, Aetna, they've been just a blanket not covered, considered experimental, and you present this data to them. And so far, it hasn't really made that big of a difference in terms of getting things approved. But, hopefully, as we're getting more and more, and I think specifically the individual diagnosis data is helpful, because then you can start saying, rather than just blanketly across the board, peripheral nerve stimulation for, pain of peripheral nerve injury, now you can say, okay, look, here's the data for these chronic knee pain after a total knee arthroplasty. Here's the data for chronic shoulder pain, and be able to really hone into the insurance companies and try to give them the right data to help them make the best choices for these patients.
Yeah, ASIP just released some guidelines in November, and they looked at 8 RCTs, I think a bunch of systematic reviews and some observational studies. So, they came out with some, I think they had 2 recommendations, and they were all, the evidence levels were fair. The recommendations were moderate certainty. So it just goes to show that we're on the right path. We're going to keep fighting the good fight. But, they did have fair and moderate certainty evidence for lumbar stimulation without trial, and also for temporary peripheral stimulation for 60 days. So, we just continue to, probably by the time we finish recording, there's going to be another study that came out. But it's exciting to see that the progress is still going, and thankfully, step fighting the good fight and publishing, and look forward to seeing more next year.
Yeah, that was a shout out to Scott Pritzloff. Thank you, Scott. We appreciate that. Doing a lot of the work in the PNS realm. But yeah, I mean, I think also one of the things that's interesting, and I don't know, Dr. Khan, how you feel, is, as you look at how people are utilizing these tools across the country, there's a lot of people that are actually, you brought up, the data of being able to go to PNS without diagnostic blocks. I think there's a lot of people that are, especially for certain indications, going to a PNS without diagnostic blocks, with mainly the theory of putting local anesthetic in an area doesn't necessarily say how the patient's going to respond to neuromodulation therapy, which I think makes total sense, right? Just because, local anesthetic works or doesn't work doesn't mean that stimulating that nerve and that region is going to work or not work. I know historically, I think we both have kind of stuck to that kind of workup process of like try to block the nerve before that region. But I know that across the country, there's a lot of people that, I think rightfully so, don't believe that there's any reason to block the nerves because they're completely different mechanisms of action. And so it doesn't necessarily mean one way or another that it's going to be helpful information. What are your thoughts on that?
Yeah, I think that's a good point. Somebody asked me that the other day. I kind of stuck to my guns and said, it makes sense to me, even though it's a completely different mechanism of action. My thought process is trying to see at least, is that involved? So is it involved, meaning that if we know it and the pain gets noticeably improved, that yes, okay, it is, this nerve is doing something to generate the pain. And I use it less so as, of a positive predictor of peripheral nerve stimulation, but rather as a confirmatory identifier. That's kind of how I
Kind of
see it.
rule out kind of more than a rule in.
Yeah. Although I have it, I guess most of the time it works. Most of the time the nerve block
Yeah.
does something. At least for like peripheral nerve, and I'm not talking. I think as most people know, it's just there's so many mimickers of pain, and it's quite challenging. If you have fusions, if you have discectomies, all sorts of other things going on, it becomes much more challenging. As far as like isolated neuropathies or isolated joints, also then the nerve block works. So I mean, I guess it does bring up the fact that is it even worth doing it before it's going to work if we do stimulate noise.
Yeah.
I still feel like doing it is probably worth it just to have the patient feel some comfort that they can go through with this, especially with the SPRINT system. I mean, I tell patients, the SPRINT system is basically an injection that takes a little bit longer than the actual injection that I did for you in the office. So there's less anxiety when it comes to that. So I think it does give me some little bit of information before I decide to do therapy for them.
Yeah, no, I agree. I mean, I have not done any PNS without doing a block, but yeah, I mean, I think the conversation's interesting because it's definitely one of the things that I've heard when talking to people across the country and kind of ways of looking at it. I think specifically like cluneal neuropathy was one of the ones that I know people have, like, oh, if you're suspecting it, like what's even, I mean, I guess the point is, if you block the nerves, can you make it feel better for a couple of hours to at least identify it? But yeah, I mean, it's just an interesting conversation, I think, and hopefully one that will be addressed in studies as we can keep going forward and being able to see the difference of kind of how people respond or responder rates based off of diagnostic blocks versus not having them. Just like everything, right? It's an evolution, and hopefully we keep getting better with it and keep using it more. Do you have any other things to bring you comfort this morning on the topic of peripheral nerve stimulation, Dr. Khan?
I think that's most of what I want to get out there is that the comfort study. I'm sure there's going to be more data coming out next year, 24 months, 56. So look forward to talking about those. Maybe we'll skip the 24 and we'll wait to the 36, just to kind of summarize it a little bit better. Especially if the data continues to be, showing similar results. I mean, I don't think anything is, permanent. It's going to last for a lifetime. If we can get years of relief, I mean, that's great. Patients that want, they get relief with SPRINT, they want to do it again. I tell patients, we're still feeling much better, then we can do it again, but we should wait and see if the pain gets significantly worse in the future.
Yeah, and I think one of the things that I think one of the things that we get into this kind of strange world in pain medicine where we want this really prolonged data is that I don't know that anybody asks surgeons for the same level of data that we're trying to ask ourselves. Not that we shouldn't want the best data, but realistically for the things that we do, you're talking about 3 years, 5 years. I mean, and then so many different pain generators and things that can kind of alter how a patient's doing over time. There's, I would argue that for, in terms of a lot of the, and peripheral nerve stimulation is a little bit different. This is probably a much bigger conversation, but most of the surgical data doesn't necessarily have, 3 and 5 year data behind it. And so, yes, it's great for us to strive for the best things possible, but, for us to expect that everything that we do is going to last a lifetime is, I think, a bit presumptuous. And so, I think, as we're getting more 12 and 36-month data that shows that things are moving in the right direction, I think that's a really, really strong indicator that, this technology is really taking off and making a huge difference for our patients.
Yeah, especially compared to the alternatives, which is really.
Yeah. Well, awesome, sir. Dr. Kung, I appreciate you joining and talking about peripheral nerve stimulation, giving us a nice, good update here. Any closing thoughts for the peoples?
No, I'm excited to see some more interviews. Not interviews, but I guess the last few months you've been talking to a lot of different folks around the country about not specifically getting into the nitty-gritty studies like we are. We're excited to see what else you have coming up over the next few months.
Try to keep everybody guessing, but hopefully.
Yeah, exactly.
Well, thanks everybody. If you made it this far, send Dr. Kung a message. Tell him you appreciate him stopping by, and tell him you like his new haircut too. All right.
See you
All right,
guys.
guys. Thanks for listening. We'll see you guys later.